All right, yesterday we talked about cervical trauma. Now we're going to talk about thoracolumbar trauma. And we're going to start by just going over a few things related to classification, and then we'll get into discussion about management. Okay, so who's familiar with the AO classification? Anyone? Who can name all 53 AO subtypes? Eric Woodard can. That's fantastic. Anyone else? Anyone else even willing to try? Okay. So the AO classification has been around for 20 years now. Really, what you should understand about the AO classification is that it boils down to 3 injury patterns, which are the compression or type A injuries, the distraction or type B injuries, and the rotational or type C injuries. And you can imagine that as you go from A to B to C, you become more severe in the amount of force that is applied to the spine and the failure of the spine. And then as you go from, hey, do you mind, can you close that door, please? Thanks. The subtypes of the A, B, and C, as you start, getting into the sub specifications of the AO classification. But basically, as you go from A to C, you get more severe, and as you go from A1 to A3 is more severe than A1. But in general, you can imagine that with the AO classification, the more severe your compression load, the more failure, the higher the degree of failure of the underlying spinal column, then the higher the grade would be in the AO classification. But no one actually knows all 53 injury patterns, no matter what they say, and people have done the studies to show that the inter and intra-rater reliability is not terribly high. But the principles are of value, and in fact, those same principles of understanding the vector of force that's applied to produce the injury pattern underlies a far more useful classification in terms of surgical decision making, in my opinion, which is the TLICS. Now, who is familiar with TLICS? And so in many ways, just like if you are on the phone and you describe a 37-year-old male who is in a motor vehicle crash who's a GCS6, you have in 15 seconds alerted the person on the other end of that phone call that they're probably coming in to do an operation, right? And if you tell someone that you have a 27-year-old who fell off a roof and is a T10 Asia A, you probably understand that you're going to be coming in to operate on that person as well. And if you're talking about someone who's neurologically intact with a TLICS score of 2, that has meaning, right? So there's value in these classification systems that we use, like the GCS, like the Asia, like the TLICS, because they communicate information in a very compact manner. The TLICS score is based on the injury morphology, the PLC status, the posterior ligamentous complex status, and the neurologic status. And you get points depending on whether it's a compression. You get an extra point if it's a burst fracture. You get points as it relates to the integrity or lack thereof of the posterior ligamentous complex, and then which is also very wise, is that an incomplete injury gets a higher score than a complete injury, which is basically inducing you to do something about the person who has an incomplete injury in the setting of neuroelement compression. And then if your TLICS score is less than 4, it portends non-operative management. Greater than 4 portends operative management, and 4 is the gray zone. And then the last thing is this load sharing classification, which born initially out of Gaines' description of this comminution index, that the goal of this thing, and no one should, you don't really need to know this. I mean, reading McCormick's paper in 1994 is actually a good read. But really the point of this is to make you think to yourself, do I need anterior column support? And the more disrupted, the more kyphotic the anterior column is, the more you should be thinking to yourself, this is a person that needs anterior column support. All right, so now let's talk about cases and management strategies. And this is all against a backdrop of personal bias, just like yesterday. So this is what I do. And there are lots of ways to skin a cat, but this is what I do. All right, compression fractures. I don't brace compression fractures. I don't brace stable burst fractures. I try to avoid the use of braces throughout my practice, whether it is elective deformity corrections. I don't put those people in TLSOs afterwards. I mean, thank God that are there still people out there who put their ACDFs in collars afterwards? I mean, does that still happen? Right? Why? Why? Paranoia, yes. You know, we have very strong evidence to demonstrate that a brace really has no role for a single level compression fracture, and really has a minor role in stable burst fractures. So, do any of you guys train in a place where people discharge patients from the hospital with a stable burst fracture and no brace? 2. Yeah. What are you doing these days, Dom? Are you bracing stable burst fractures?
You know, obviously the trick is your definition of stable. My attitude with bracing is closer to yours, probably not quite as draconian, but you know, I don't brace any of my ACDFs. You know, 1, 2, 3 levels. You know, the 1, 2, 4 level. I use that. I wouldn't brace. Most fractures I don't brace, but you know, flexion, compression fractures, simple fractures like that, I definitely wouldn't brace. You know, but if someone has a burst that I consider, if I consider unstable, I'm generally going to operate on it.
Right.
If I consider it stable, I'll treat it non-surgically. Those I typically will brace. So you know, like
which ones will you brace?
A burst fracture that I consider stable. So someone comes in with a 3-column injury, let's say in the lumbar spine, 20% canal compromise, you know, less than 5 degrees of kyphosis, but it's 3-column, the sets aren't sprung, it looks like ligaments are okay, get an MRI, the guy's neural intact.
So that's a TLICS score of 2.
Yeah, so that guy, and one of the reasons is that I think it helps to ambulate them. I think that when they have a brace, they're more apt to get out of bed, and more apt to get out of the hospital. I think if you don't brace them, I think they're less apt to be up and about, and they're less apt to tolerate getting up. I mean, those fractures are painful,
yeah.
And so I get what you're saying from a stability perspective, but from a functional perspective in terms of, I don't want you to go home and start riding your motorcycle right away, or I want you to get up and be able to get out of the hospital, I typically will brace those.
What I'm looking forward to is when the Apple Watch comes out and we start getting better health apps for our mobile devices, and then we can actually start tracking things like whether people are getting up and around with these health conditions, and secondly, whether they actually ever put on the brace that you just spent $1,000 on. Will be very interesting. You know, I'm looking forward to that being a part of the kind of apps that get developed around what's coming through the pipeline with the Apple Watch. But I agree with you, and we'll talk in a moment about a patient.
Also, just to finish the thought, Dave, you know, I think that I see my bracing go down even more. Like I said, my philosophy is really not to brace. I don't brace after any of my lumbar fusions or anything like that. Some of these bigger scoliosis cases into the thoracic spine, down the pelvis, I'll consider bracing those, especially if they're osteoporotic. But right. My attitude is a lot more like yours, but I've seen it move even more now that we can deal with these burst fractures in a minimally invasive fashion. In other words, you know, just putting in pedicle screw fixation, if you can get one at the level, one above, one below, those patients I will not brace, and not that I push patients to go one way or another, but I tell them, look, you can be in this brace for a couple, 3 months, and you may or may not heal, you may or may not be kyphotic, or we could do this 1-hour operation, and you might be able to go home tomorrow kind of thing. And so I think that's cut into the brace usage as well.
What do you do, Paul?
I think you have to feel into it, but I probably agree with Tom. I lately would do quick screw fixation, and it's interesting because in the thoracic spine, I'm not even sure it needs to be removed. People argue that now you doing two operations, one for them you're not using it, you're going to second operation remove it somewhere down the line.
Yeah, but what about the what about compression fractures? Do you brace them? Do you brace those patients?
It depends on the situation. I think, I'm not maybe uniform for what I look at the patients, what they're going to do. There's some patients don't, I want to say 90% of my patients that brace, when I see them in follow-up, they're not willing to brace.
Precisely.
I go, where are you brace?
At least it costs $1,000 though.
Well, some TLICS are like 3 or 4 grand.
Yeah, well, we're in a very aggressive pricing environment at UPMC. We pretty much tell people what we're going to give them for it, and then they give them as little as possible. All right, but is there evidence behind this? Turns out, yes, and there was even a randomized prospective trial that looked at A3 fractures, so these are at the more severe end of the burst fracture, and whether there was bracing or no bracing equivalence in pain and 1-year x-ray outcomes. There were 3 failures in the TLSO group, 1 failure in the no brace group, and then Moeller has published these 2 fantastic papers. So as it turns out, in Finland, they've had a common medical record in a socialized health system for 40 years, dating back to the 1960s. And so this is an opportunity for data mining in retrospective fashion, and went back through, and 23 to 41 year follow-up rates, 23 to 41 years, absolutely no difference between bracing and no bracing. And same thing in late adolescence, 27 to 47 year follow-up, absolutely no difference whether there was a brace or not involved in the management. What about unstable burst fractures? And so what I do is, and this is really below T6, because above T6 it's hard to factor in an anterior approach. And you're just less likely to do an anterior approach above T6. So below T6, what I do is if when the patients are incomplete or they have one of those high gains comminution indices, I'll do an anterior corpectomy, structural grafting, and then either an anterior plate or plus minus a posterior instrumentation. And then I'll do posterior only for the intact patients without much destruction of the anterior column, or for complete injuries where you can still get a decompression through a posterior approach. And actually, what I've started doing recently is taking those from the PSO tray, those vertebral body breakers, those little paddles that we use to break the posterior vertebral body at the end of a PSO, and I'll slip that underneath the dura for burst fractures and actually bang the retropulse fragments back forward with that little device, is what I'll do if I'm doing a posterior approach for that. So that's what it looks like when we're going from the front. And, so these are posterior constructs versus anterior constructs. When you do an anterior approach, it opens the door to shorter posterior constructs. And then with Adam Cantor in Pittsburgh, we've been doing this for, I think the first one was in about 2009. So gosh, we've been doing this for 5 years now. For well-selected patients, we'll do this minimally invasively. So you can, make a 5 centimeter incision, and we can get corpectomy, cage, and anterior plating all through a 5 centimeter incision. That's what the incision looks like, and that was her X-ray, which is so that's a nifty little thing, and I think Juan talked about that a little bit earlier. So it's nice to see some of these minimally invasive approaches having their indications expanded. All right, what about flexion distraction injuries? This is mostly posterior, 360 degree for severe canal compromise or incomplete injuries where you're going to get an insufficient decompression from the back. And fracture dislocations, I pretty much do most of these posteriorly, but if it's an incomplete injury, and again, I'm concerned about maximizing decompression, I'll consider a front back in those patients. And what you want to do is you want to think of the goals. So the goals are realignment, decompression, and stabilization ultimately, right? This is a nifty little trick that I first learned from Mike Steinmetz in Cleveland. And if you can see here, so this is a patient who has a fracture dislocation of the thoracolumbar junction. You can put in your pedicle screws and then put 2 rods horizontally, so not vertically, but horizontally, and and actually get a really nice reduction by just taking 2 rod holders and grabbing onto those rods, and then you can reduce the fracture with pretty good control, pretty nice control. So you can see there's the dislocated facets, basically, you know, jumped thoracic facets, and in just a moment here he'll nicely reduce this. Pretty sweet little trick. So putting the rods horizontally. Gunshots. So non-operative treatment of gunshot wounds is the standard. We know that steroids are not applicable to this patient population, irrespective of what you think about it for the non-penetrating population. Antibiotics are not indicated for gunshot wounds to the spine, even if they traverse the canal and have CSF. They're not indicated unless there's colonic perforation. So that's the only indication for antibiotics. And then we're all tempted to go in and debride these things, and that's really not a very good idea either, because you're opening the door to trouble. So decompression is rarely of benefit except for, and this is data from the Spinal Cord Injury Model Systems database, an intracanal bullet between T12 and L5. The removal of bullet fragments that are inside the canal between T12 and L5 was associated with better motor function at 1 year, but just between T12 and L5. And these fractures are usually stable despite a 3-column injury. So again, operating on gunshot wounds to the spine should be a rare event. They rarely produce instability, and there really isn't much of a role for surgical intervention unless there's a bullet inside the canal between T12 and L5, or you have something else random like a persistent CSF leak, which I can't remember ever having actually seen that. And the outcomes are most dependent on the spinal cord injury itself and the associated injuries. There is a high incidence of CSF leaks with unnecessary decompressions. There's an extremely low incidence of CSF leaks when you just leave these people alone. And bullet migration is rare, but does occur. And Jeff Manley actually had a case of a cervical bullet that migrated up to the foramen magnum and caused a new neurologic deficit in a patient of his. All right, so a couple cases. 52-year-old male, motorcycle crash, thrown from the motorcycle, landed on his rear. He's neuro intact, okay? So let's talk about this, because this is how we're going to finish this up. We got 5 minutes. Nathan Rowland.
Yes.
Where are you, Nathan? Oh, hey, what's going on?
So this is a sagittal CT scan showing a 2-column fracture at T12. There's a little bit of retropulsion. I would say that there is maybe 10 to 20% canal violation. I don't see a lot of L5 forming here, and there's about maybe 50% vertebral body height loss.
Is there anything else you want to know?
Well, let's see, so his exam's intact. How long ago is this?
An hour.
His Asia score?
He is intact.
Asia.
He's in Asia E. Are there any other studies you want?
Well.
So from an AO perspective, what would this be?
The injury.
A, B, or C? Just A, B, or C?
I think it would be an A.
Correct. And the TLICS score?
Well, let's see, the TLICS would be, so it's a 2 because it's the vertical morphology would be a 2.
Mm-hmm.
The posterior was complex. And I think this
this will be either 2 or 3. It's either indeterminate or it's injured. I can't tell that from an MRI.
What if I tell you we went ahead and got an MRI?
Okay. So this is now that same sagittal CT on the left, an axial cut of the CT on the middle, and a T2 MRI sagittal cut on the right. On the right, I see what looks like an intact PLL at that level.
Yep.
And I don't have a stir sequence to see if there's any more intense signal there. So I think that this means it's intact. So that would be a 0.
Right. So his TLICS score would be what?
It would just be a 2.
All right, nice job. What do you want to do?
So for him, he's intact. 2, his TLICS score is a 2. And based on our discussion of bracing, I think I would just watch him, have him come back to clinic in 3 to 4 weeks. Maybe just get plain films and make sure that's stable, make sure he has no other symptoms, and just continue to follow him. Have him return to clinic if he has any problem.
Totally reasonable. Turns out this guy couldn't stand up without an intolerable amount of pain. And so then we did the oldest treatment of all, which was rest. And we just said, okay, bed rest for a few days. And gave him a couple days of bed rest, tried, still couldn't do it. It's now 5 days later. He's still unable to get up and around. So we gave him a brace, hoping, like what Dom was pointing out, hoping that the brace would help this guy ambulate. Turns out that didn't help either. So now it's 5 days. We've tried multiple times to get this guy up, brace, no brace, and it's still untenable.
So did you get dynamic imaging, like a flexion extension, just to see if this is?
We got a standing X-ray right there, which was quite painful for him, but he managed to stay up long enough to get an X-ray.
And all of your efforts at just pain management, medical pain management.
We tried it all. And this was his only injury.
Yeah. Well, I think the principle here is that he is in a lot of pain, but he's neuro intact and his injury seems stable. I still would not operate just based on him having intolerable pain. I would try whatever I could to try to.
What are your options?
To manage his pain.
No. What are your options at this point? One option is pain management.
So we could observe. We could try non-operative measures such as which you guys tried, rest, bracing, etc. Surgical options would be to provide a few. He doesn't really need decompression per se, but you could fuse him 2 levels above and 2 below per the lanky traumatic model, and see if that helps his pain. But I don't think that's likely. I think I would still try to just manage this non-surgically.
Okay. We did percutaneous instrumentation, and then he immediately got out of bed the next day. But so we did perc screws, and then this goes back to what Paul brought up earlier. So he did great, and then the question is, do you take this out a year later? And so is there anybody who's still taking out instrumentation a year later? Is Juan still here?
We don't do it.
You don't?
No.
What are you doing, Paul?
What
Well, actually, I've had discussions with Juan about this, and I think it's very similar. A lot of these patients, they're good, well, just never come back. I mean, there's a lot to follow up. I don't know exactly what happens, but there's a couple papers out that would suggest that if the patient is below altitude, you might want to consider removing them because there's so much motion that they'll eventually halo if you're not using it. But anything above altitude, you could probably leave them in because particularly in the thoracic spine, there's not that much motion. And I would have to say anecdotally, I haven't looked at my series, but I remember I did ER nurse once. He came in after a motorcycle accident and did a fracture. Did what you just did right here. And he had a lot of other injuries, but I didn't see for 2 years. I don't know what happened to him. He's part of our system. He came back and image them, and it's true, there's no place, I didn't use it or anything, and there's no healing.
What,
Anecdotally, it's one example, but there's some retrospective studies that just won't happen.
what's your opinion on that, Rusty?
I don't do pertaining screws, but the Pies and Nod County Hospital said him do it, and I think he does plan on taking it out at 1 year. Now, I don't know if he's specifically designated certain levels or not. I'm not sure.
And what are you doing, Dom?
He's leaving it. They don't have a problem with number one, number two. As Paul said, they don't, a lot of them don't come back. If they're doing well, if they're not doing well, you can hear about it. And so we don't plan on taking them out. I mean, obviously, we're not against taking them out. If someone says they want them out, if they're having problems or if there's a failed fusion, you know, it's not unheard of, but we leave them in.
So,
Yeah, Pat.
what's wrong with sending this guy home with a, bottle of Loganox and tell him to stay on his couch for a couple, 2-3 weeks? I mean, if you broke your ankle and you had a, distal tib fracture, the last thing in the world that we would do is tell you, hey, why don't you get up on this tomorrow and tell me if you have pain? Of course you wouldn't. You wouldn't even, you'd be non-awake for 3 months anyway.
Yeah.
So why do we treat the spine so differently? And I do this, I'm guilty, I break the spine, yes. But this is, you're putting in 6 screws at $800 a lot, 2 rods, OR, general anesthesia, blah, blah. And I'm guessing, best case scenario, this is 25 grand, right? That episode of care. And long-term outcome in terms of pain and things like that, surgery, no surgery, doesn't matter. Is this really cost effective? It's faster.
Right.
10 years from now, is it more cost effective?
Yeah, and that's a fantastic question that I don't actually know the answer to. But when you start factoring in what would be the number of DVTs or PEs or the number of pneumonias or the number of something else that it would take to actually convert this into a cost-effective intervention, I'm just saying that out loud. I don't actually know the answer to that question.
I think those are very good points, but when we look at it, it's going to be DVT, 50, to probably not going to get a pneumonia. You're right. I think the 78-year-old who comes in like this, that's a much more difficult problem because acutely they're not great candidates for vertebral augmentation. You're right, the brace is meaningless in those guys and it does nothing for axial loading, which is probably the main generator of the pain. I don't have a real good treatment for those people.
Well, I think it needs to be individualized. I treated a MA who worked for one of our endocrinologists, and she slipped on ice at a fracture, just like an AO3 fracture. And in fact, she came to the issue brace. Month, couldn't return to work, couldn't get out of bed. So I ended up putting percutaneous screws. She went back to work. She takes it 3 weeks later. So I think loss of work, it has to factor into it.
Yeah, but spending $25,000 to get someone back to a $50,000 a year job, 6 weeks sooner is a valid question. And but then you have to factor in all the other costs of because the narcotic use is actually less in people who get this percutaneous instrumentation than in people who are treated non-operatively. If you want to know the answer to the question of is it cost effective, there's a way to do that, and there's a way to calculate that, and it starts becoming much broader and more complex than just focusing on the $25,000 episode of care for the surgery, which is not to discount the validity or importance of the question. Rusty.
And it may play a role in the multi-trauma patient who's going to be going back and forth to the OR with abdominal surgeries, chest surgeries, where you basically have an internal brace to make that safer.
And it has become crystal clear that in people who have unstable spine fractures, that early intervention has a very long list of benefits and is clearly superior to waiting, as far as mobilization, hospital length of stay, medical complications, faster transition to rehab, etc. So for unstable fractures, early intervention is clearly superior and cost effective. This is a stable situation, and I've never actually seen the cost analysis. The cost effectiveness analysis of this particular intervention is probably long overdue for someone in the room who wants to tackle that. All right, who's next?
Can you comment on that X-ray right there?
Yeah.
Is there any issue you think of having a robotic rod at that level?
Right, and so this case is actually from 2009. We took his instrumentation out a year later, and we've given up on we don't take the instrumentation out anymore, and we also don't use this particular system anymore, because this system you're sort of induced to use a lordotic rod, and the system we use now, we have lots of options and we can bend the rod to whatever we want. So it's a good point, but we took his instrumentation out a year later anyway.
How do you take it out? Can you use the same percutaneous incisions? Or do you have to do
No, and the irony of it all is that we did a midline open approach to take it out.